So I'm reading this paper on a chest wall reconstruction with anatomically designed 3D printed titanium ribs and hemisternum implant. This tomorrow we have a case of chondrosarcoma, which is he's a 52-year-old male patient with a big mass 15 cross 10 centimeter involving both the medial end of the clavicle, sternum, up to manubrium xiphoid, and also right side 4 and left side 5 ribs. So, and we are going to reconstruct it using the 3D printed titanium ribs and sternum. So I found the similar paper, so it will give me some idea about how this um, procedure takes place. So first we'll see this paper. We'll read. So chondrosarcoma of the chest wall is a rare and when diagnosed requires a full thickness wide local excision of the tumor and chest wall to ensure tumor free margin, minimize local recurrence and contribute to long-term survival. However, a wide local excision of the chest wall results in a large defect, and reconstruction of this defect require a combination of skeletal reconstruction and soft tissue cover. And the reconstruction is a complex and challenging. Traditionally, the skeletal reconstruction has been performed using various techniques, including a mesh and methacrylate orthopedic cement prosthesis, that is MMCP, methyl methacrylate orthopedic cement prosthesis, and this can only be prepared at the time of surgery and is time consuming. It is difficult to mold into shape and has the potential for dislocation, resulting in a paradoxical movement during respiration. So development of this 3D laser printing technology for titanium implant that can help simplify this challenge and reduce the surgical operating time. I may describe the use of this technology in an adult male who underwent a wide surgical excision of a chest wall chondrosarcoma followed by reconstruction using a large skeletal defect with a custom made 3D printed anatomical ribs and hemisternum titanium alloy implant. And the implant mimicked the anatomical contour and size of the skeletal reconstruction required. So he is a 70-year-old male ex-smoker presented to this hospital in with a right anterior pectoral mass measuring 10 cross 9 centimeter, and patient is the coronary artery disease with previously having ischemic attacks, and a chest CT showed a tumor arising in the right anterior chest wall beneath the pectoralis major and separate from the muscle but involving the underlying ribs, and there was a minor scalloping of the rib 3D anterior third anterior rib, and the tumor was located anterior to the second third fourth ribs, and no radiological evidence of pulmonary mediastinal bony or liver lesion. So histology was chondrosarcoma with a long-term survival, necessitated not only wide excision but also removal of the right pectoral muscle and second to fourth rib and intercostal muscle and portion of the hemisternum. And given the extent of reconstruction required, the limitation of the methyl methacrylate method to model ribs is need to preserve the normal thoracic anatomy and function. The importance is to keep anesthesia time to minimum, considering the underlying coronary artery disease. And it would be possible to use technique outlet the manufacturer processed PMMA polymethyl methacrylate implant prior to surgery, and the far superior bio compatibility and strength offered by a titanium implant. So preparation at the maxillofacial laboratory service at Morrison Hospital under the guidance of the surgeon. This sub-millimeter digital imaging and communication in medicine DICOM CT data into Mimics Medical 20.0 software, Belgium. Manual bone threshold segmentation was performed to create the 3D virtual model of the patient's chest and tumor, and this was digitally reconstructed in a 3D from the sub-centimeter CT slices, and as the CT scanner data varies from case to case, used manual adjustment by eye, and which was previously helped us provide best results over autonomic segmentation and region growing, and was used. The ribs were clearly visible on a CT slices to produce a sternolithographic files, and the sternolithographic files of the ribs and the tumor and sternum was reported into Geomagic Freeform plus software 3D system Rock Hill, United States, and they estimated the extent of resection needed to ensure tumor-free margin by growing the tumor by 2 cm in all around and achieving clear microscopic margin. An anatomical image of the rib and right hemisternum be reconstructed and then digitally obtained to form the chest scan, and then proposed titanium implant as a single part of titanium alloy was fashioned to mimic a shape and contour of the rib and sternum. And at the overlapping and fixation sites, the contour of the underlying rib laterally and sternum medially were carefully imitated, and the aim was to implant anatomically fit into the surface of the remaining fragments of the excised 3 ribs and the sternum, and to keep the implant light yet robust enough to withstand the stress placed on the chest. The design was limited to 1.2 mm thick at the overlapping fixation site, and the body of the implant was however designed to be thicker than overlapping edge to create a rapid step shape recess for the implant to slot into the defect and prevent any future dislocation. Suture holes were placed to attach the implant to the bone with a interrupted size 5 ethibond XL polyester suture to provide robust fixation, albeit with an expectation that movement at this interface would be obligatory, and hence provide some flexibility to the rib cage during breathing. So 3D printed model of the implant and sternum in resin were printed with a Formlab Form 2 stereolithographic printers, and the process resection of the sternum carried out in our 3D maxillofacial laboratory, and the rib sternum implant was found to fit precisely the 3D model of the defect area, and hence the decision was made to proceed to final implant, and the implant was manufactured from the titanium alloy by a metal powder fusion technology, selective laser melting. Heat treatment was performed after printing, and the implant was brought to the temperature of 850 degrees Celsius, which was held for 1 hour, and after finishing the TI part, all the parts underwent bead blasting with alumina 60 grit hardened coarse flap wheel grinding to remove support witness, and 3-stage tumble deburring. And once this was complete, various grit polishing wheels were used to bring part of this design finish, and the part was then steam cleaned to remove any polishing finishing residue, and then put through nitric acid passivation. Further detail regarding powder bed fashion printing are beyond the scope of this case. So this was the case, a manual bone threshold segmentation to digitally reconstruct the tumor, and enlarging the tumor digitally by 2 cm to estimate resection margin, plus plane surrounding the tumor show potential resection of bone and cartilage. The area to be removed is in yellow. The area to be removed is in yellow. An anatomical image of the rib and the hemisternum obtained digitally from the CT scan, and the titanium plate implant fashioned anatomically to mimic the shape and surface contour, namely the depression and ridge of the sternum and ribs. So at the surgery, the right LD, latissimus dorsi muscle was harvested as a pedicle muscle flap based on the thoracodorsal artery with the patient in left lateral decubitus position, and the harvested muscle was placed in the right axilla and the donor wound was closed, and the patient was placed in a supine position. An elliptical skin subcutaneous incision was made to excise the biopsy scar. Full thickness skin and subcutaneous tissue was raised above and below incision. An underlying pect major muscle was exposed, and by excision of the pectoralis major minor tumor deep to the muscle and the intercostal muscles were then carried out. The second to fourth rib divided laterally with a costotome, and the right hemisternum divide and manubrium divided medially with a hall saw. And the 3D test model in resin was used as a template to determine the cuts, and cutting guides are manufactured in a sterilizable stereolithographic resin, namely dental SG, and printed on a form left from two printers were supplied but not deemed necessary, as a 3D test model provided a suitable guide for the cuts and to make minor adjustment to the rib and sternal heads, and the resected specimen was removed for histology. 3 to 5 centimeter of all around macroscopic margins were achieved, and intraoperative frozen section of histological examination for microscopically clear margin was omitted to operative and surgical anesthesia team. And to reconstruction, the 3D test model of the implant was first tested on a resected area and was found to slot in and fit the defect perfectly. And the Gore-Tex mesh was secured to the under surface of the ribs and sternum with the interrupted Athibond 20 sutures to prevent lung herniation through 3D implant. And the 3D printed titanium implant prepared earlier was then placed on the surface of the remaining fragment of the ribs and sternum and secured into place with the Athibond 5 sutures, which is routine practice for securing MMCP to the chest wall and to the implant. Unlike other titanium devices that are secured with screws, was not secured with screw due to osteoporotic nature of the ribs and sternum and the narrowed remaining hemisternum and predisposition of screw to migrate out over ribs over time. The skeletal reconstruction was then covered with the previously harvested pedicle LD muscle flap and the wound closed in layers. This is the implant placed in surgery and the follow-up of the chest radiograph. Histology confirmed 8 cm grade 1 chondrosarcoma. Minimum of 2 cm margin was all around achieved, and the post-operative recovery period of regular chest physiotherapy were provided, and hospital discharge was delayed due to prolonged drainage of serous fluid from the harvest site. 18 months follow-up, the patient was asymptomatic, walking without any walking aid, and tremor of his hands were resolved, and he described no breathlessness, pain, discomfort, and paradoxical movement at the implant site. On the post-operative chest radiograph and 18 months of follow-up, there was no gross evidence of dislocation or tumor recurrence. So the use of 3D laser printing technology to construct the custom-made anatomical 3D printed titanium rib and hemisternum chest wall implant is useful adjunct to the surgeon that helps reduce the technical challenge and operative time required for reconstruction of the large chest wall defect. And the personalized 3D printed titanium chest wall implant helps preserve the anatomical shape, structure, function of the thorax. Long-term follow-up is required to validate the clinical efficacy and safety of this technique for chest wall reconstruction. Thank you.